Good morning, everyone. So here we are in week 12, coming up to the end. Got a little bit more of female reproductive to do, but that's about it. I owe you a couple of videos. I realize that. I hope that my life settles down enough that I can get them recorded before the week is out. Um, I'll be posting a quiz on the female reproductive stuff uh, today, and we'll go from there. So this morning I thought that I would talk a little bit about ovarian cancer and ovarian problems. Cover that. But before we get started with that, does anybody have any questions, anything, any comments, anything that they want to bring up or deal with? No, nobody's got a hand up. I see it's the usual suspects here, for the most part. Okay, how's everything going in other classes? Is the crunch on? Yeah, I have no doubt that it's busy. Yeah. Oh well. So that's probably why we've got a small turnout this morning, smaller than usual. In any case, are we cool? You want to just jump right into it and do some ovarian? Great. That's what we'll do then. Um, well, maybe I should turn the video on. I was going to use a different computer this morning because of the problems that I've been having with this one, with my laptop. Um, but the other one didn't have a camera, so I thought, well, maybe I'll give it another try. Okay, so if we're going to talk about ovarian cancer, it's here. Um, Now it's in your e-book, chapter 10, at page 11, disorders of the ovaries, ovarian cancer. Now, uh, the numbers are uh, pretty close on both this book and the uh, the other book. So both Werner uh, and the main textbook, the ebook, but it's probably got to do with what year. So when the demographic says 20,100 diagnoses a year, and the other textbook says 23,300. It could be, one is quoting 2007, the other one's quoting 2005 numbers, but it's in that neighborhood. So ovarian cancer is malignant tumors of the ovaries, and it is cancer, so it's epithelial in nature, and there is uh, a fair amount of epithelium in the ovaries. Uh, the big problem with them is that uh, they grow very quickly, and they metastasize, through the peritoneal fluid, rather than through lymphatics, because the ovaries are sitting out there in the peritoneum. They're pretty much out there on their own. Even the fallopian tubes, where they come close, don't actually aren't connected. So if you look at these numbers, 20,100 diagnoses a year with 15,000 deaths. According to the other textbook, it's 23,000 with 15,300 deaths from ovarian cancer in '07. That's a pretty poor outcome. Uh, when you look at it, that means there's like less than 5,000 actually live. Um, so it it's the fifth leading cause of cancer of death for women, not cancer death, but of death. So it's up there with car accidents and gunshots. You know, it's really quite high, and it's got this very poor outcome, mostly because the it's far advanced by the time there's a diagnosis made. It's already metastasized. Uh, so uh, 90% of these things are epithelial in nature. Some of them can be stromal, so they'd be connective tissue, and some of them are more germ cells, which are the ones that are going to give rise to gametes. But most of them are epithelials. Um, most, like three-quarters of the diagnosis are made at stage 3 or 4, which is really bad. So METS happens through the peritoneum, or it can happen through blood and lymph. But nevertheless, that's where it goes. You know, that direct extension sort of thing, because the organs of the abdomen are pretty close together. Morning, Ashley. Okay, so they don't really know what causes it. Uh, it happens in people that are kind of perimenopausal, postmenopausal. So there's probably some sort of uh, hormonal component to it. There's probably an environmental component to it. But there's definitely a genetic component, because it really runs in families. The first degree relatives is a 1 in 3 chance of developing ovarian cancer. So it really is probably some sort of a genetic anomaly, some sort of a gene that's being carried that makes you susceptible to the environmental factors. I don't think that you inherit the the thing. It's just you inherit the propensity for it. Oh, I see, Neil. Jim is there. Good morning, Jim. Um, okay, so there's other things that put you at risk. Nulliparous, so no children, is at risk. Um, no birth control, right? Uh, seem to be at risk. Both of these things, what they have in common is lots of ovulations. Um, as I said in one of the other videos, I think the endometrial uh, video, that it's we think that, okay, every 28 days ovulating, once a month is the normal thing. And really, for most of human history, it's not the normal thing. Most women between the ages of 16 and 40 were pregnant almost every year, or they were breastfeeding. So ovulations were way down. And when you think about what an ovulation is, it's a like that oocyte, and the Graafian follicle grows and then bursts through the epithelium of the ovary. It's like a pimple that bursts, and that leaves something that has to be repaired. And if you think that that what cancer is basically screwing up repair of minor damage, and that's when the mutation happens. That's when the changes happen. Then there's more chance of that. The more repairs you have to do. So um, it increases the risk by not having pregnancies, but by ovulating a lot. Um, so that's really wear and tear on the ovaries. Um, there's also seems to be an issue that uh, that it's estrogen. Now the ovaries obviously respond to estrogen. That's part of their job. That's part of estrogen's job, is to regulate things. Um, so the thing is that uh, estrogen levels are probably higher now than they've ever been. Uh, the women are not having as many babies, not having as many pregnancies, so they have estrogen for half the period every month, whereas in the past it was more a progesterone dominated thing because you were pregnant or breastfeeding a lot. Um, the There are a lot of outside sources of estrogen, including plastics and getting into our food, uh, probably hormones in various meats and foods, you know, and soybeans, like all that soy extract, has estrogen-like compounds in it. So that seems to be a big issue. These other things like asbestos and talcum powder on the genitals is something that I don't quite understand. It's whatever. Um, but high fat diets are important, as probably is weight, um, because fats make estrogen, and they also store estrogen because it's a fat soluble hormone. So estrogen levels are high with that. Age is a big factor. Probably most it's it's 50s and the 60s that it happens, the peak. Is this making sense so far? Thanks, Jackie. Okay, so it's pretty silent, and as I've said before in other videos and other times, the scary thing about a lack of symptoms is that people don't get detected. They don't get treatment early enough, and once something's metastasized, it's not good. Um, so uh, so it's funny. There are cancers that give lots of symptoms, and people think that they're horrible because of the lots of symptoms, but generally they're not fatal because they're caught because uh, they're caught early. Whereas cancers like pancreatic cancer and ovarian cancer that really have no discernible symptoms, or the symptoms are so subtle they can be put off to other things, um, it's it's already in stage 3 or stage 4 before it gets diagnosed, and the prognosis isn't good because of that. So what are some of the symptoms? Feeling of heaviness in the pelvis, bloating, nausea, diarrhea, constipation, urinary frequency, vaginal bleeding, uh, changes in the cycle, weight gain or weight loss. Talk to the average 50 to 60-year-old woman and ask them whether those about those symptoms. Like the, that's really perimenopause that you're talking about here. Uh, I mean, middle-aged women with with uh, urinary frequency, constipation, you know, uh, throw in sleep disorder on that. Like it it's really easy to pass off, and not only is it easy to pass off for the person that will stop them from going and getting uh, screened or diagnosed about it, but it's really easy to pass off for family doctors. Like when you think about the pressure that those guys are under, you know, their patient comes in, they've got 40 patients booked that day, and so they got like 4 minutes or 5 minutes to have this discussion, and you get a 55-year-old woman in complaining that her urinary frequency has changed and that she's spotting, and you know this her menstrual cycle seems to be screwed up. Well, the first thing you're going to jump on is perimenopause, and you know it, it's it's a problem for those people that actually have ovarian cancer. Uh, Statistics, though, are that um, it probably is perimenopause. You know, so uh, if it gets later and the tumors have gotten big, then there might be a palpable mass. But even then, how many kind of lumps and things, you know, and how are you actually going to go palpating in there? Most women don't even know where their ovaries are. They've got this idea that they're up on either side of the belly button of the umbilicus, and that's because referred pain from the ovaries is up there. So if the woman has metal schmarts, which is the sharp pain during ovulation, or if they have like ovarian cysts or anything like this, and those things all add to the risk factors. The place that they feel it is up beside the umbilicus, and where the ovaries are really down, almost right behind the superior pubic ramus. They're very low uh, in the pelvis, not in the abdomen. Um, so half the time they don't even know where they are and feeling for them. Um, so they make the diagnosis if they suspect it, and they do some screening. Uh, they they find them on ultrasound. I think probably more are found on routine ultrasounds or the ultrasounds for other things than than actually going and looking for them. Uh, so so the you get this mass on the ultrasound, and then you better freaking biopsy it. You better do go in with a laparoscope and biopsy it, because there's really no other tests. And see, that's another problem, is that it's an expensive, invasive thing to um, make the diagnosis. So you have to have a pretty strong suspicion of it to do it, uh, and people and doctors are probably reluctant to do it because their suspicion isn't strong enough. The blood test is not definitive, so at this point, its diagnosis is difficult. Um, it says here in your textbook that 90% of women with ovarian cancer reported experienced symptoms long before the diagnosis, but they're nonspecific and vague. Uh, and often misdiagnosed. So it's misdiagnosed as perimenopause or irritable bowel syndrome, things like that. Um, this is not going to show up on Pap smears. It's not going to show up um, on those sorts of things. So surgery is the treatment of choice, but it kind of depends on at what stage. So they're definitely going to go in and take them, and they'll probably take all the adjacent tissues. Maybe you do full hysterectomy, but definitely the ligaments and the supportive tissues, that kind of thing. Probably will try and take lymph nodes, so a lot like breast cancer, where they'd be looking. Uh, it uh, that's what'll end up happening. Um, So Neil, nothing shows up reliably on ultrasound. If the mass is big enough and it's caught, then yeah, it can be seen. But really, ultrasound, I don't know if you've seen ultrasounds, but I mean, I have a very good working knowledge of anatomy, and I have to kind of close one eye and stick my tongue in the side of my cheek to try and imagine what it is that I'm looking at in ultrasound. There's a lot of noise in ultrasound, and it's easy to miss small things, or diffuse things. If it's a well-defined mass, then it's easier to see. But what if it's not a well-defined mass? What if it's kind of a diffuse uh, collection of cancerous cells? So, yeah, it's tough. So, because most people already have meds by the time it's diagnosed, chemotherapy is huge for it. So they give a couple of different types of chemotherapy too. They not only do they give chemotherapy intravenously for systemic things, but they also give it intraperitoneally. So they put it right into the peritoneal space, and try and deal with stuff there. And when you think about it, uh, uh, when you think about it, the peritoneum, that space, is, for all intents and purposes, outside the body, and so the immune system doesn't work worth a shit in out there. Like, it doesn't cross the serosa very well. That peritoneal fluid is um, not a very good place for the immune system to work. So, uh, it's not as bad as completely outside your body, but it's uh, it probably needs help, uh, more so than things that are in an organ within your body. Um, so that's probably the the reason that they do both types of chemo. Uh, I would say that people caught in stage 3 and that get this chemotherapy have a higher chance of actually making it. If it's stage 4 and there's mets, I think that probably most of the treatment is palliative. It's probably got more to do with quality of the remaining time that the woman has. Um, uh, a lot like pancreatic cancer in that respect. Um, so, how does this affect massage? Probably it's something to be aware of. You probably don't want to do very much lymphatic work or circulatory work, and you probably would want to work in with teams, like with the healthcare team, and be aware of what's going on. Um, I don't know how many of these women actually end up on your table. Um, that's a good question for somebody in your techniques class or your theory classes. So that's it for uh, ovarian cancer. Anything that good morning, Mackenzie. I hear that you had a funeral. Sorry to my condolences. Okay, so no questions, no comments, no nothing about ovarian cancer. Okay, well, the next ovarian problem, and probably the other very common problem, are ovarian cysts. Ovarian cysts are uh, little fluid-filled uh, spaces on the ovaries. You can get cysts anywhere, but there's an awful lot of women have ovarian cysts. So these are normal ovaries. It's a hormonal issue, and again, like I say, we one of the things of the 21st century is that we have a lot of hormonal. Uh, yeah. I'm sorry, you were out of the country for that funeral, Mackenzie? Oh, okay. Uh, had me a little freaked out for a second. Okay, so who gets ovarian cysts? Well, women who are using their ovaries. So this is between puberty and menopause. The If it happens before puberty or into um, in past menopause, then there's a higher chance of them becoming uh, a problem and turning into cancer, ovarian cancer, which we just talked about. They actually are been seen in the ovaries of of fetuses, the girls yet to be born. Um, Now, one of the things to remember is that women have all they're born with all the oocytes they will ever have. The When you think about it, the ovaries are fully formed before birth, and they're ready to go. They're just in a latent period. Excuse me. Um, so why not? If these cysts all grow around those follicles, thank you, Neil. If the cysts grow around those follicles, then why can't they be found? But it's probably going to happen in response to the hormones like FSH, LH, that kind of thing. Um, yeah, let me just look over here. Yeah, we're going to just do this really quick because really it's not even on in this E10. So, um, but I think it's important. One of the issues is that there's an awful lot of women get these, and they can give some problems. Uh, so what really happens is that Graafian follicle doesn't rupture and there's no ovulation. And if it doesn't regress or heal over normally, it just leaves a little cyst that takes up space and impacts the function of the ovary. Uh, so really, those would be called follicular cysts. Uh, they might spontaneously resolve. They might stay there. It kind of depends. Sometimes after ovulation, the corpus luteum uh, will, which normally would produce progesterone, uh, ends up with some scar tissue or some, let's say in here, a blister over that site, and it ends up filling up with fluid, and it's really in the corpus luteum. And if that's the case, then what's going to happen uh, is that there's going to be too much progesterone. It's going to seem like you're pregnant uh, for quite some time, and if they're bleeding, remember you're not going to spot it. It wouldn't be vaginal bleeding. This would be ovarian bleeding, and the ovary is in the peritoneum, so the blood will accumulate kind of probably down in the pouches, like uh, the uh, the little pouch between the bowels and the uterus, or the one between the bladder and the uterus. Um, yeah, and you can end up with little, maybe even calcium deposits in there from the hematoma. And so it looks like this. That looks like a huge cyst. I think most of them are probably smaller. The pictures that are uh, in the book make it look a little smaller than that, but it's a large one. Um, a lot of women get polycystic ovaries, and so multiple small cysts, and this is an interesting thing, because what ends up happening is, when you think that the hormones, the estrogen and the progesterone, are made by the follicular cells that are surrounding these normal uh, secondary and Graafian follicles, that if you have multiple ones of these going on at the same time, you will have way more hormone, which leads to possibilities of other diseases like breast cancer and uterine cancer and that kind of thing, because the hormones are kind of screwed up. But it also leads to, because a lot of these things are changed into a testosterone, so it leads to a lot of male uh, characteristics, hair growth, things like that. And it's like young boys at puberty. So what it does is it causes acne, things like this. It'll disrupt the cycle, because remember, the menstrual flow doesn't happen until estrogen and progesterone drop to almost zero. So if the estrogen levels stay really high, then it's going to disrupt the cycle. Um, uh, the testosterone, or the estrogen that becomes testosterone, uh, really increases libido. And it's interesting, because a couple of semesters ago, there was somebody uh, in my class, when we were talking about this, who has this problem. And after class, she came up and talked to me and was telling me that she has a real problem with libido. Like uh, it's almost to the point where it distracts her um, from studying and from all kinds of things. She said it was a real problem. Uh, it will raise your metabolic rate. It impacts on the thyroid and on all the cells, and metabolic rate will go up. Um, so uh, another problem that happens in ovarian cysts are things called dermoid cysts. We're going to not really worry about the endometrial and cystodemas, but the dermoid cysts. And what's crazy about the dermoid cysts, and I've talked about ovarian dermoid cysts before, because they can turn into what are called teratomas. uh, which really means monster tumors. And I talk about one that is at the U of T. It's about the size of a volleyball, and it's cut, and it's got teeth and gums and hair in it. The teratomas are really interesting things, and because what happens, they're called dermoid because they start to look like skin, and what they do is they grow all the appendages of skin. Uh, it's uh, it just is a testament to what can happen in tumors, especially of epithelial origin. Do you think you can post it, John? I don't know. Can you can try and add content? Sure. Okay. Keep talking. I'll give it a go. Um, Actually, if you just even post the website, we can probably go here and do it. Oh yeah. Okay. Um, oh really? Well, that's interesting. Um, well, if you can't post it on here, maybe you can send a copy to me, and I'll post it if you want on the Blackboard, just so people can see it. Okay, so yeah, dermoid cysts are really quite interesting things. Uh, I, we went. I took a group of students to the pathology museum at the U of T one time, and that's the dermoid cyst is the talk. Everybody forgets everything else they see because this thing is so freaking dramatic. And then about uh, 3 weeks later, one of the girls in the class was having some problems, and she went to see the specialist, and she ended up having to have surgery, and I had one of her ovaries removed because of a dermoid cyst. Well, it was nowhere near what this thing was at the U of T, but boy, the class sure went crazy, thinking that it looked like it was going to have hair and teeth and everything. It's like having a baby. Um, so these are what the cysts look like, and you can see that it's kind of got that Swiss cheese appearance, and it's going to impact the functioning of the ovaries as a as an endocrine organ and as a as releasing gametes. Uh, so it's it is a real issue, and people have trouble with it. My understanding is that it's a dull ache. There's not a lot of symptoms. You know that, uh, and this is where it comes into play for us. That it's referred pain. Uh, right, you're absolutely right. It's unless the ovary torsions, because and the reason it would, and I'll kind of get into that, is that the ovary becomes unbalanced, and it really is sitting on a little stalk of ligament that's off the end. So if it becomes unbalanced, so like say there's a lot of weight at the top of it, then gravity is going to make it just twist to the bottom. And the problem with that is then blood supply will be disrupted, and there'll be spasms, and there will be all kinds of things. So that can, I my understanding is that that can be very acute pain. Um, I'm going to guess that that yours torsioned. Am I correct in that assumption? Yeah. And was it a real medical emergency? Like it was like they did something immediately about it? Oh, okay. Uh, well, turning back is probably a very good thing. Yeah, it's and these things can get huge, especially the dermoid ones. Like I say, this one at the U of T is the size of a volleyball or a soccer ball. It's freaking huge. And when you consider that the ovary itself is about the size of an almond, picture a volleyball sized growth on an almond. It's not a that's quite a visual, isn't it? Um, yeah, it's yuck. I think is the exact correct medical term for it, Melissa. Um, so uh, when they get big, the space they take up becomes a huge issue. They can push on the bladder, they can push on the rectum, they can push on all kinds of things. Like we just said, they torsion, they can be a real problem. Uh, they will be masses on the ovary that may show up on ultrasound, so it can look like ovarian cancer. So really, there are real complications to this, and it's really very common to have them. So like I say, the ultrasound finds the mass, but really doesn't know what it is. It could be cancer, could be anything. Uh, so if it's fluid filled, they sometimes just suck the fluid out of it, aspiration. They might do surgery, maybe even take the whole ovary or take part of the ovary. Um, if it's um, if it's the problem is that they're functional follicular ones, then you screw around with the hormones and try and make it so that they just spontaneously reabsorb and you don't stimulate them anymore. So and that's really what birth control does is it prevents the follicles from developing so that you don't ovulate. It acts as a birth control. Well, it has this helpful bit in these functional cysts at least. Um, so local contraindication to massage, but especially if they're functional and they're fairly small, it's probably uh, fine to work everywhere else. It's probably more just a talking point and something that if you're informed about it, a lot of women are quite concerned about them. And there's not a lot of information out there, so uh, being informed on it is probably a good thing. Okay. Okay, so email me the link and I will and I'll put it on Blackboard if you're amenable to that, Jillian. Um, and if you're not, then that's fine too. I'll find some links to some teratomas. So, what do you think? It's been a remarkably quiet morning. It's more of a monologue than a dialogue. I'm glad that people are at least typing comments. And thank you for your input. Um, so it's week 12. Next week's week 13, test 3. Uh, so it will pick up from where test 2 got to and go right to virtually the end through menstrual disorders. And the pregnancy disorders are really short: preeclampsia, eclampsia, um, gestational diabetes. Um, No, no mic. Um, so look for the quiz probably this evening. I got a full day. Um, Actually, I got a freaking crazy day, and which is one more crazy day in a crazy week. So I will have the rest of the videos posted by tomorrow. I will have the quiz up by this evening, uh, and all in preparation for next Thursday's test. The test will be remarkably similar to the other two, and in the same room. Uh, Next Thursday at 8 o'clock, it will be yeah. Uh, so it's probably going to be around 50 questions, and then uh, we'll talk about the exam uh, that day that we see you. I will probably also post something on about the exam. It's going to be in a different room. I've got the room number, but it's not handy right now. And uh, it will be a comprehensive test. I will also post study quiz um, that to help for the whole exam. It will be just like the study quizzes that you've already had, but bigger. Uh, yeah. So awesome it will be, Mackenzie. Uh, okay. Um, I apologize for the tardiness in getting these videos posted. It seems that my week falls that it's difficult to get this done much before about now, um, but as long as you have it before the starting, I guess that's the important bit, right? No, the final exam will be longer. I think I've got 2 hours booked. Um, you won't need it; it'll be 100 questions, but yeah. You have video projects in another course? Okay. Uh, Theory 3. Okay. It's not easy doing videos, is it? Okay. Well, with that said, have a good week. And we'll talk to you later. Yeah, I agree with you, Neil. I'm finding that each one of these 15-minute videos that I do for this course ends up taking me probably over an hour. Uh, just there's a couple of takes on it. There's yeah, just getting everything prepared and then uploading the crap. It's yeah, I've got it down somewhat. The first ones were just brutal, uh, but whatever. Uh, well, there's no commending. I actually feel bad that I'm not more proactive about it. But thanks, Sarah. Okay, so we will talk to you. Uh, we'll see you in person next week. Okay.